All right, welcome back, everybody. In this lecture, we are going to be actually introducing ourselves to the very last area of psychology that we'll be discussing this semester. It's one that we've actually been alluding to a number of times in the previous lectures, but we're going to try to kind of address it head on in this class and the subsequent following classes. And it's a branch of psychology that's nowadays called clinical psychology. Now, when we talk about clinical psychology, there's lots of different things to address. Because of our kind of odd schedule this semester, we're actually skipping one topic that we often address in this when it comes to something called the DSM, or the Diagnostical and Statistical Model of Mental Disorders, or Manual of Mental Disorders, sorry. And this particular manual is something that really is a critical element to both the diagnosis and kind of plans for treatment of a wide variety of different mental health issues. The DSM is something that's been around for a long time. There are some things around the topics of assessment that we like to talk about, but since we sort of had to get rid of one particular aspect of clinical psychology just to meet the schedule, that was the section that I decided is just not as quite as important as some of the other stuff that we did still want to talk about in this class. We're going to kind of skip ahead in this material and talk about what usually is the second topic within clinical psychology, and it's how people in the profession of clinical psychology try to help individuals with a variety of different problems. But it's really important when we get into this area, and this is again something we typically do in the lecture that's scheduled before this in most semesters, to kind of talk about some really important things before we try to tackle different clinical psychology concepts. One of the first and most important things that we really want to understand when we get into clinical psychology is that this is not considered kind of a profession that just explores the unusual and the weird. Unfortunately, in clinical psychology's history, there was a penchant for lots of individuals to just be enamored with talking about the weird and unusual and not really consider the fact that the people behind those weird and unusual behaviors were people. And that still persists today, with a large number of individuals feeling stigmatized and feeling kind of ostracized as a result of a variety of different mental health issues they have. Another thing that's really important when we talk about clinical psychology is that the scope of this profession goes well beyond just some of the mental disorders that we're going to be talking about in future classes. There are a wide variety of individuals that go seek out clinical therapy, and they do it for a wide range of different purposes. Some people are sometimes tasked to see a clinical psychologist because they have what's called a diagnosable disorder. Again, we sort of would have talked about this in previous semesters about this when we discussed the DSM. We will talk about some specific diagnosable disorders in future classes as well. And this is, again, a reason for why some people go see a clinical psychologist. But there's also a wide range of other reasons why people see clinical psychologists. Some might just have specific behaviors that they decide are undesirable or just atypical and they want help with them. Some people might just be experiencing large amounts of stress or want somebody to just talk with to kind of help them through either just the aspects of life or certain things that they're kind of struggling with at the moment. What I want you to get from this is that clinical psychology is a very broad profession, and there's lots of individuals that go seek out clinical therapy, and there's lots of different people that help individuals in different ways within this branch of psychology. And this brings me to another really critical point, and that's the fact that when you finish this class, I want you to remember that just because you've learned a little bit about clinical psychology does not make you a clinical psychologist. It's a weird phenomenon, and this is actually why many intro instructors have tried over the years to kind of avoid clinical psychology as a whole. But for some weird reason, people, when they learn a little bit about clinical psychology, decide that they can then help others with the very limited base knowledge that they have. It doesn't happen for pretty much any other area of psychology out there. Nobody, once we've decided to cover neuroscience, thinks of themselves as a neuroscientist now, and Very few people think of themselves as professional social psychologists or personality psychologists after going through those classes. But when people learn just a little bit about this, they then tend to start diagnosing their friends and family members and trying to treat individuals just based off of the limited amount of information that we're going to cover in a class like this. That is not something I want you to do. That is very kind of dangerous when you start getting into that area. Because people who get into clinical psychology not only have undergraduate degrees in psychology, but almost all of them have moved on and earned at minimum a master's degree, with majority of them nowadays earning either a PsyD, PhD, or an MD to specialize in their particular area within clinical psychology. So one intro class on clinical psychology is just a small amount of exposure to this field in comparison to the people who have multiple semesters of this as an undergraduate and then usually take multiple years of clinical psych classes and then have multiple years of training in different contexts before they call themselves clinical psychologists. So if you can keep those two big things in mind, that clinical psychology is a very wide-ranging thing, and you do need to be trained before you would even consider trying to take what we're covering here and apply to others, and that people who go see clinical psychologists are indeed people, and the stigma associated with it is real, then you should be better equipped to kind of go through a lot of the stuff that we're going to be talking about today. And what I thought we should do to really get things started is look at how this particular area developed when it was once called abnormal psychology or just kind of abnormal behaviors. And to understand why that term or concept came about and why other philosophies on mental health still persist today, we actually have to take a journey quite far back. If we go back a number of centuries ago, what we see is pretty much every culture had their own philosophies on beliefs as to where the abnormal thoughts and behaviors of certain individuals were coming from. There were very few cultures throughout history that didn't have numbers of individuals within them displaying kind of atypical behaviors, behaviors that were either problematic for them or problematic for the society as a whole. But what each culture decided was the cause of these things varied. Many cultures tied a lot of these mental health issues to spirituality issues. There was the kind of possibility that people could be possessed by demons or some type of deity was messing with the head of an individual. It varied from culture to culture as what the source of these problems were, but these ideas eventually evolved into attempts to treat these individuals through some pretty aggressive techniques. Processes like trepanation, where you cut a hole in the skull of individuals to theoretically let out demons and problems, were not necessarily commonplace, but have been discovered in a vast array of different cultures when we've dug up bones and found individuals with skulls with holes drilled into them and then sort of healed over. Exorcisms were somewhat common things in a lot of different religions where they tried to kind of chase or scare demons away. In fact, the Catholic Church is still to this day tied to exorcisms, even though for those of you that are wondering, know that Christianity, Catholicism is not necessarily something that kind of we should be tying to exorcisms nowadays. But there's lots of horror movies and others that kind of bring out this notion that spirituality and mental health were considered hand in hand, even for Christianity or the Catholic faith. Another thing that we often see is that many cultures tended to kind of see these abnormal behaviors as lifelong persistent things. So there were lots of issues with people kind of being separated from their groups within the culture because of the kind of prominent beliefs that were held, not only about what was causing these things, but how permanent these things were. And it wasn't until about the 16 and 1700s, as science started to grow, that beliefs about the causes of these mental health issues started to change. Unfortunately, when these changes started to take place, it didn't necessarily take a turn for the better for a lot of individuals with mental health issues. As we started to understand the concept of illnesses and airborne problems, there was a persistent belief that started to be floated in the 1600s and 1700s called the somatogenic hypothesis that surmised that mental health issues might be kind of synonymous with physical ailments and physical maladies that people were struggling with. In essence, you could catch depression or you could somehow come down with a bout of anxiety disorder where it was actually traced back to some type of biological thing that was the source of these problems. And with this philosophy in mind, lots of different communities around the world started to develop these things that they called hospitals. And I put that term in quotes intentionally because their definition of hospitals at the time was very different from our current definition of hospitals. For these hospitals, oftentimes people were chained up to walls and kind of left there for their lives with this kind of belief that there was really no other way to handle individuals with these mental health issues. Again, there was this prominent belief that these people were sort of incurable and had caught something, and well, we wouldn't want these people to be exposed to others lest they might catch whatever mental illness these individuals had caught. So as, again, we transitioned from more spiritual ideas to more airborne mental health issues being kind of the new philosophy, it didn't necessarily make life better for lots of individuals who had a variety of different mental health problems. It just transitioned the lives that these people were experiencing. And this idea actually persisted for over 100 years. And it wasn't until actually the early 1800s that this philosophy started to change. And it was really due in kind to the work of a very prominent gentleman in the Parisian hospital system named Philippe Pinel that we started to kind of see a subtle, small change that eventually started to become more mainstream. When Pinel was put in charge of Paris's major hospitals, he started to try to figure out ways to kind of make these programs more efficient and make them more effective. He essentially was tired of seeing people being chained up to walls and being viewed by tourists as these kind of freakish anomalies that everybody should just kind of appreciate for their oddities and not recognize as people. Fennell started to unchain these individuals, interact with them, try to see what the source of their different problems were, and he started reporting that when these conversations were happening, many of these people started reporting feeling better, and more importantly, the doctors and nurses that were willing to do these things were not reporting mental health issues suddenly after the interactions. And these recognitions started to really catch on to actually be incorporated into a number of different hospitals and different facilities throughout not only France, but the world as a whole. And by the mid 1800s, there had been a new shift that started to take place that kind of saw mental health issues not as incurable and not as spiritual, but something else, something that kind of had a mental connotation to it. This was exactly the world that Sigmund Freud and some other individuals that we talked about in previous class stepped into when they started introducing their theories of where the source of different mental health issues could potentially be coming from. And when Freud started talking about his psychodynamic theory of mental health being really a byproduct of childhood experiences and drives and traumas, he started this shift, this seismic shift in clinical psychology, where people started looking not only at the biological components that were potentially linked to mental health issues, but the psychological and the social factors as well. We definitely went through a number of evolutions since Freud, but nowadays, what most people do when trying to understand mental health problems is they abide by something that we often call the biopsychosocial model of mental health. It really highlights what most people focus on now when looking for the source of different problems. That this kind of interaction between our biology, things that were actually going on within us, and this can not only be at the cellular level, but also at the genetic level, that we could look at psychological factors, which is the stresses and the mental thoughts that people are having that can contribute to mental health issues, and the social factors, the environmental things that are either strengthening or lessening the chances of different mental health issues and maybe bringing out specific mental health issues within people. Now, this biopsychosocial model is often paired with another concept called the diathesis stress model that suggests that when we're looking at our proclivity to develop specific problems, we shouldn't be just looking at people's biological inclinations for this. We should be looking at what's going on at the moment in the environment that could enhance a person's likelihood of developing things that they maybe have a predisposition for. Diathesis being the biological predispositions, and the stress being the environmental cues. And all of these new approaches, these new frameworks, have been growing in psychology for a number of decades and have kind of been the replacement for our traditional past views on mental health issues. Still, probably a large number of evolutions that the field has to go through, but today there is definitely a very different take on mental health than what doctors, what people in psychology had just roughly 100 years ago. And what we want to do from this point on is not only just look at what we now think of as the cause of different mental health issues, but how we might help people when they do develop these problems. So, how do we address then the different problems that people have when it comes to mental health? When people are looking to address the biological side of things, some of the old tried and true methods are sometimes still done. Well, one thing that is still done in rare cases, but still done nonetheless, is something called psychosurgery. When somebody has some extreme issue that doesn't seem to be explained through any type of kind of social interaction, there are many times that people will get their brain scanned and they will look for things that might be awry. Now, in the past, psychosurgery was more of just tinkering with the brain and hoping that something could work if you sliced off certain portions. Lobotomies or kind of attempts to remove portions of the brain to help people, not necessarily commonplace about 100 years ago, but they were things that were sometimes incorporated into treatment approaches when people's behaviors or mental functioning was extremely astray. Nowadays, psychosurgery is more reserved for when you can identify something physically wrong with the brain that needs to be corrected and can be corrected through that method. Something often tied to psychosurgery in the past was this other thing called electroconvulsive shock therapy, where you try to adjust the brain not through removing portions, but essentially resetting it through a huge amount of electricity pulsing through different courses, different sections of your brain. For those of you wondering if you do have some mental health issues that you'd like to talk to somebody about, know that there is no way, zero chance, that these options will be presented to you. There are still occasional moments where psychosurgery happens, but again, there's something specific that people are looking for when these things occur. And there even are some very rare cases where electroconvulsive shock therapy is incorporated into treatment plans. But even those new techniques are very different from what we had in our historical perspective. But for the vast majority of individuals, if the biological side is being addressed by therapists, it's usually through the incorporation of medication into treatment methods. And medications nowadays come in a variety of different forms. Essentially, all of them are trying to do the same thing, find ways to kind of reorder the balance of the presence of different neurotransmitters in the brain. And in doing so, if you remember back to what neurotransmitters are for, what they're really trying to do is either tamper down the activity of certain cells in the brain or increase the activity of certain cells in the brain. That's again, neurotransmitters are the chemicals that these cells are using to communicate with each other. And there's a variety of medications that have over the years proven to have a pretty robust effect on different sections of the brains and a variety of different symptoms that are tied to the functionality of different systems within the brain. In fact, lots of research has shown that a variety of different drugs that have been developed not only work very quickly, but can help with a vast array of different problems that people are struggling with. And this particular reasoning is why oftentimes medication has started to become kind of the go-to for lots of individuals with mental health issues. The problem with this as being the catch-all way to solve these problems is that it oftentimes maybe misses the source of the inappropriate functioning, I guess you could say, of the brain. There's lots of concern that essentially what people are doing when trying to help people with medication is physically fix something that was caused through a completely different source. And it's causing large numbers of individuals to take massive amounts of medication to try to balance things out, become potentially addicted to these things throughout their lives, and to have kind of a need to continue to up the dosage of lots of drugs because of issues with tolerance and of whether or not these drugs might have other side effects over time if you do go off of them. And this is really problematic. One of the best analogies that I've ever heard to really highlight why this is such an issue is one where researchers or clinicians kind of equate a person's mind to a car. Right? They say, let's say you hypothetically have a car that starts leaking oil. So you decide to take it into a mechanic, and that mechanic looks it over, and the person says that there's definitely a need to put some oil in the car right away because the cars need oil. And if you don't have oil in the car, then lots of really bad things could happen to a variety of different components. So if the mechanic puts oil in the car, you probably won't even think twice about it. You'll probably think that that person's pretty sound. I can pretty much guarantee that if that mechanic then tells you, looks like we fixed the problem, just make sure every day or so you put a little bit more oil in, you might no longer think that highly of this mechanic, right? You might start to question whether or not this person really is a sound mechanic. But that's kind of what we're doing with medication, right? We're just giving people oftentimes medication and saying, just keep taking this and you should be fine, when we're not necessarily going to the source of the problem. We're not in the analogy looking for where the leak was originally created. We're just kind of keeping things balanced. Or most clinicians say, look, it's not that medication is necessarily a bad thing. It's just that we should probably do it in conjunction with other types of treatments, trying to find the source of the problem in the first place. We're going to talk about how we can source this out a little bit later. But before we leave this biological side of things, I do want to mention one last thing that started to pick up a little bit more in recent years. And it's an attempt to try to address the clinical side of things through actually looking at people's genes, looking at their biological structures. There's been lots of debate over the years about whether or not genetic inclinations are kind of guaranteed when somebody is kind of tested as having the potential to develop a variety of different mental health issues. And it's also led to a debate of how much information we should be able to know about a person before they've actually had a chance to live out their lives. There's a big debate over whether or not parents should be allowed to test their potential offspring for potential mental health issues. There's obviously some logical reasons as to why somebody might want to do this, right? If you're thinking about having children or thinking about getting eggs fertilized, maybe it does make sense to try to have a child that doesn't have lifelong issues that are going to make things much more difficult. But obviously, that logic can quickly go astray, and you can start talking about things like designer babies and trying to inject certain gene combinations into different cells to try to create the perfect child in a wide variety of different ways. And this starts to get really uncomfortable and awkward once you start thinking about this. But it is kind of a new frontier And it is something that people are thinking about when, say, they get their genes tested, was whether or not they can figure out if they maybe have a proclivity for something like substance abuse issues or depression issues. But the kind of world of whether or not this is clearly ethical or unethical is still kind of unsettled. And until we really kind of grapple with what genetics and mental health have to do with each other, we're probably going to continue to kind of wrestle with whether or not things like genetic counseling and genetic testing for mental health issues is an ethical thing or not. But if I didn't mention it, I'd probably feel like I didn't really cover one of the other major components to the biological side of trying to address mental health issues these days. I do want to go back to that car analogy now and kind of let us recognize that many people in clinical psychology, again, do see medication, maybe even some type of physical intervention as potential paths to helping people with the symptoms they're struggling with. But they do tend to feel that going to the mental side of things, the stress, the thoughts, is a key player in helping individuals. And this brings us to the next set of topics that we're going to be discussing, really for the majority of this class. And it's this process that psychologists call psychotherapy, where treating mental health issues or people's struggles with from day to day issues kind of is focused in on trying to address different thoughts and different components of the mind that people have maybe tied to the mental health challenges that they have. The idea is here that if you can catch those thoughts or catch those stressors and try to address them, well, then maybe those undesirable thoughts and behaviors or even disorders can kind of be abated, or the symptoms can be lessened through this type of help. But what I want us to understand when we get into psychotherapy is that how this talk process can unfold, what you want to address, varies dramatically from clinical psychologist to clinical psychologist. Historically, if we look at the early inklings of psychotherapy, for a long period of time, psychotherapy was kind of synonymous with something we've talked about before called psychoanalysis. When Freud introduced his psychodynamic theory of not only personality, but also mental health, lots of individuals trying to follow in his footsteps spent a large amount of time when trying to help clients looking at childhoods, looking at the unconscious, looking at all of these horrific things that were maybe going on within us in order to try to help people with a vast array of different problems. Psychoanalysis often involved not only large amounts of talk with a therapist, but things that we've talked about before, like free association techniques, hypnosis, dream interpretations. And to kind of really help somebody through this process of psychoanalysis, Freud and other people that followed in his footsteps intended that this would be kind of an exhaustive thing that would take large amounts of time. We're talking years here, and be extremely interactive before even a small amount of change could take place. This was kind of the only game in town for a long period of time. So lots of people, when they started trying to become clinical psychologists in the early 1900s, tended to just follow in the footsteps of Freud. As the pushback for Freud started to take place in the 1920s and 30s, other alternatives to psychotherapy started to emerge. One really interesting counter to psychotherapy, or not psychotherapy, sorry, psychoanalysis, that started to emerge in the 1920s and 30s is something that we nowadays call the behavioral approach to clinical psych. And essentially what the behavioral approach does is it uses the tenets that we've talked about previously, like classical conditioning and operant conditioning and the ideas of learning being a critical player in our behaviors to try to help people with a slew of different problems. Now, the behavioral approach is oftentimes seen as a really good and effective tool for specific disorders like fear-based disorders. Phobias are one in particular that tends to be tied to it. I'm not sure that that picture of snakes is going to help anybody overcome their phobias, but things like exposure therapy, where people are put in a situation with the thing they're most terrified of, is considered to this day still a common technique that can help Obviously not to that extreme. I don't know why I had that dramatic picture in there, honestly. But it can help in those situations. It's also proven to be very helpful for drug use issues and eating disorders. There's a wide range of things that behavioral approaches have proven through multiple research studies be a very effective tool in. And when it was developed, it was really just seen kind of as a counter to the psychodynamic or the psychoanalysis approach that Freud and his colleagues had been promoting for a number of years. As counters to this approach started to emerge, like the behavioral approach, other ideas started to take shape as well. One of the big ideas that started to take shape that's really evolved into different things over the years is something called the cognitive behavioral approach to therapy. And this particular approach essentially combines the research of cognitive psychologists and behaviorists in a way that tries to help people to not only change what they're doing, but kind of reassess the thought processes that are engaged when they're encountering situations that kind of trigger the abnormal thoughts and behaviors. And CBT is not necessarily a perfect panacea for all problems, but many people in clinical psychology for a number of years, and even still to this day, tend to describe CBT as the gold standard for most clinicians. What that means essentially is if you want to show that you have a new technique that's very helpful, you need to at least show that it's more helpful than CBT, because cognitive behavioral therapy tends to be, in general, a pretty darn effective technique for a vast array of different issues that people are struggling with, be it a specific mental disorder or just a wide range of different problems that people are struggling with. Now, as CBT has evolved over the years, there's been different kind of specialized treatments within the umbrella of CBT. One of my favorite examples of this was actually one of the first ones to emerge, called rational emotive behavioral therapy, that focused primarily on people's direct reactions to situations. There was actually a therapist named Albert Ellis who championed this idea in the 1960s and 70s, and his big push was to just challenge people's thoughts and reactions when their abnormal behaviors or kind of uncomfortable behaviors and thoughts started to emerge. And it really was seen as kind of a big alternative to a lot of the other stuff that had been developing in the early infancy years of clinical psychology as it was kind of trying to take on this new form. Another thing that started to pick up at pretty much the same time is something that we sort of nowadays call the humanistic approach to clinical psych. There's another term that's often used to describe this called person-centered therapy that kind of really highlights the logic or the rationale for this approach, where instead of having a clinician lead everything, the person who wants to get help really gets to take the reins. They're kind of given the ability to explore what they think they need to explore, and the therapist or the clinician is really just there to help this person on their path, to provide kind of unconditional positive regard, and to kind of make the person feel like they're on a team and they're working towards some end goal. Rogers had other things within his humanistic theory that were also applied to this approach. The idea of selves and getting them aligned became a critical component to this type of mental health treatment. And still to this day, there are many individuals that kind of abide by this humanistic approach and this belief that people are often best helped by just being allowed to help themselves. One might be sitting here thinking that this humanistic approach doesn't seem that far off from CBT. And in essence, there is a lot of overlaps between these two things. But to kind of see the contrast between them, I always like to ask students to do something kind of weird. And it's actually to go to YouTube and watch just a few minutes of two really interesting videos. These videos actually both involve the same person, a woman named Gloria, who's very famous in clinical psychology because she was one of the very first people to ever be filmed in a clinical setting. She was definitely one of the first person to have her interviews be widely distributed. And what you'll see in these videos is her being interviewed by two different therapists. One of the first ones, I think it's the top one, is an interview that Gloria did with Carl Rogers, where he lays out what his humanistic approach is like, what he wants to accomplish, and then he interviews Gloria about a variety of different problems that she's struggling with. The other video is of a really famous CBT therapist that actually introduced the rational emotive behavioral therapy that we talked about before, named Albert Ellis. And in Ellis's interview with Gloria, even though he talks about similar things to what Rogers talked about, his kind of demeanor, his interactions with her is very different. And I really do want you to spend a couple minutes watching these videos. You don't have to go through the entirety of the videos, but just a few minutes watching them so you can get a sense of how there is a pretty stark contrast between the humanistic approach and CBT. And that might give you a real better sense of kind of some of the alternatives that clinicians are having to consider when they decide to get into this profession, because both approaches, even though they've evolved and focused on different things over the years, still are in circulation today. And in fact, nowadays, in addition to having those different philosophies, there's also different approaches to therapeutic sessions that have started to kind of merge as well. One thing that's picked up a lot of steam over the last couple decades is this thing called brief therapy. Anybody practicing brief therapy will suggest that it's something that can be done to kind of expedite the helping process and make people feel more empowered. In these brief therapy sessions, essentially somebody goes in and sees a clinical psychologist or psychiatrist. They talk about what's happened over the course of, say, a couple of weeks or a couple of months. The therapist kind of tries to figure out if medications or some type of plan actually was effective during that time. And then they lay out a path for what they're going to do for the next couple of weeks or couple months. These therapeutic sessions are usually extremely short. They can be anywhere from 5 minutes to, say, a half hour or so. And that might seem like a decent amount of time, but in the grand scheme of things, that's a very minimal amount of time in comparison to things like CBT and psychoanalysis. Another technique that's pretty effective is, not pretty effective, but pretty popular nowadays, is something called group therapy, where multiple individuals will actually see a clinician at pretty much the same time. And group therapy is something that's sold as kind of being a means of multiple people hearing similar problems, feeling like they're not alone, and being able to bounce off treatment ideas with other individuals. Now, I keep talking about these things as kind of being sold in a specific way, is oftentimes most people nowadays in the clinical field and to see these things as not necessarily evil, but for lack of a better term, a necessary evil due to our current healthcare systems and our current structures that we have within the mental health industry. There's oftentimes a shortage of time for clinical psychologists, a shortage of clinical psychologists in the world. So many people are forced to only see people for a very short span of time and very rare occasions. The only way to circumvent that is to either kind of adopt this brief therapy approach or to have lots of group therapy sessions to try to help as many people as possible within a short period of time. It's not to say that these things aren't effective, but whether or not they're more effective than individual therapy is definitely debatable. There might be certain instances where it does help a person more than, say, an individual therapy session would, but that is not necessarily true for the vast majority of the population. But nonetheless, these things have picked up in popularity a lot over the last couple decades. Something else that's picked up in popularity over the last couple decades is something that seems a lot like group therapy, but there's a subtle difference between it and group therapy, and something called self-help groups, where essentially the nuances of group therapy are there. Lots of people are coming together to try to solve a similar problem, but in self-help groups, the therapist is essentially removed. Now, the quintessential self-help group that I'm guessing many of you have heard of before is something called Alcoholics Anonymous. You'll learn about this a little bit more in sections as well. But I want you to understand that self-help groups exist in a number of different forms. It's not just Alcoholics Anonymous that's the only self-help group that's ever been designed. Some help with addiction issues. Others help with specific problems that each person is experiencing similarly. Some self-help groups deal with things that people just want to work on within themselves. There's a wide range of different self-help groups that are out there, but what makes them self-help groups is that, again, there's usually no therapist involved, and it's only usually just people helping each other as they're going through whatever they're going through. These self-help groups, again, can be effective. They can have very specific value to specific individuals, but they're also seen like group therapy and brief therapy as something that's more really a byproduct of our times and certain current situations that kind of cause these things to need to come into play more than these things being the best solution for everybody. If we are looking for something that is actually different from these other techniques and is not just a trend because of society, but a trend because we do see lots of efficacy in it, there's another approach that's picked up in the last couple of decades that oftentimes now is called integrative psychotherapy. In the past, it did oftentimes get labeled as something called eclectic therapy, but most people tried to do away with that name because eclectic therapy, when it was starting to be designed, was kind of tied to this notion that therapists should just, when trying to help people, learn a little bit about every area and every approach to clinical psych and just try to throw whatever they can at a person who's struggling with something and see what sticks. Nowadays, when people call themselves integrative psychotherapists, they tend to imply that they've spent an exhaustive amount of time being trained in a lot of different areas of clinical psychology. That they've spent time maybe specializing in CBT, rational emotive therapy, if that's one that they're focusing on, or dialectical behavioral therapy, something we haven't talked about in class. They might have also been trained in behavioral therapy. There's lots of different types of things that people often get trained in nowadays. And when they see somebody, essentially what they do is they try to figure out what best fits that individual when they start the therapeutic session. It's not that they're going to throw everything at them. They're going to just try to kind of cater the therapeutic sessions to that person and what they seem to see as kind of the prominent concern that needs to be addressed. And this particular approach is often nowadays very science-based, where you look at percentages of people that have been helped by different problems and how different techniques have kind of panned out with pilot groups or other groups. And in doing so, these things usually, or this particular approach is usually very effective. There is obviously a lot of concern with whether or not people can pick and choose correctly in this profession, but if people are trained appropriately, integrative psychotherapy is not only just a new trend, but it seems to be kind of the thing that's going to emerge from all the different conflicting philosophies that are out there, where we don't do away with, say, the humanistic approach or different approaches within the CBT umbrella, but we just kind of try to figure out which thing helps best with which problems people are struggling with. And what I want you to see from this is that there are lots of different professions that are out there in clinical psych, but there's also still kind of room for growth, and there will be an evolution of this field, even as you are perpetuating yourself through undergrad and graduate school if you do decide to get into psychology later on. Now that we've covered this topic of different professions within clinical psych, or I guess different takes within clinical psych, we're going to turn our attention in the remaining classes to actual mental health disorders. I need to reiterate before we do that, and I will talk about this again in the next lecture, that just because somebody's seeing a clinical psychologist does not mean that they have a diagnosable disorder. There's a wide range of reasons for why people might see a clinical psychologist. I also need to reiterate that if somebody is diagnosed with a specific disorder, that doesn't mean that they're broken or that there's something wrong with them. It simply means that they have a collection of different thoughts and behavioral patterns that have been described as some type of disorder. That's it. Nothing more, nothing less. And if we can kind of go into that section keeping that in mind, it might help us better understand the different disorders that we're going to be discussing, but also appreciate that this is something that's a very personal thing to a vast number of individuals within the population. And being sensitive to these topics is really critical. With that being said, I'm going to bid you adieu for today, and I'll hopefully see many of you very soon when we get into the next topic of clinical psychology in specific disorders. I'll see you then.